Hello, Clinic Review family. It's Dr. Sharon with Clinic Reviews. Today I'm going to be talking again about physiologic adaptation, complications, and treatments. So complications and treatments is looking at the complications of common things that go on in the hospital. We're going to be talking about vents. We're going to be talking about tracheostomies. We're going to be talking about potassium disorders, right? So common physiological problems that go on in the hospital, patients we care for, and the complications of those things. And can you identify what the complication is based on the symptoms? And then what do you do about it? So this is not your typical, oh, all I need to use is common sense here. You do need to use common sense. Okay, that's not what I'm not saying you don't. What I'm saying, these are higher level questions. You don't have to get 100% of them right in order to pass NCLEX, but you do need to get a certain number of them right. And so I want you to really test your knowledge here. You're really testing knowledge. Can you identify what the complication is based on the symptoms? So that's your knowledge and clinical reasoning. And then do you know what you should do about it? Remember, we're thinking generally. So don't think about the patient that you had last week who had these complications. You have to think in general, what do we do for this complication? So let's go ahead and get started. Hello, my friends. Today we're going to be focusing on SATA questions. In the past, I've done a lot of SATA questions, and I haven't been doing as many lately, but I did want to focus on SATA questions here. You should expect a minimum of 40, that's 40 SATA questions on your NCLEX. That does include SATA extended answer questions that you get in Next Gen, but you answer the extended answer, like if you have extended, is anything where you have more than 6 options, so 7 or more options is extended SATA questions, but you answer them the same way, right? So what you do is you turn them into a series of true-false statements. And you say, is it in general, is this true or false as it relates to the problem in the question? So you always have to relate every answer back to the question itself, and that's what we're going to practice doing today. So in addition to you having to have good knowledge, good clinical reasoning, you have to know how to answer SATA questions. So there's a lot of components to doing well on these specific questions. You know that this channel primarily focuses on NCLEX prep. We're part of the Greater Clinic Review organization. Mark Klimek has been around for a long time, over 40 years. He's been doing NCLEX prep for a long time. We have this channel as an opportunity for you to get to know us, so you can see that we know what we're talking about, so you can see that we're real people. We're a very small organization. There's only 4 of us that work within Clinic Reviews, 4 reviewers, Pete, Trevor, me, and Mark. So it's only the 4 of us that work with Clinic, and so we wanted just to kind of have you get to know the organization. If you go to clinicreviews.com, you can sign up for some of the products that we sell. We sell a 21 plus hour NCLEX prep. It's online on demand. You get it for a minimum of 3 months. You can pay a little bit more and get it for longer if you want to. Mark Klimek actually does teach that. And then we have small group tutoring. It's a package, 4 sessions over a 4-week period. And I am part of that. So if you want to meet me live over Zoom, you can sign up for the small group tutoring. And then we also have the streaming service, which provides all of the YouTube videos plus any videos I've deleted. And I've just recently deleted most of the year 1 videos. We're into year 4. It's July 1st, 2025. This is the first day of our year 4, starting year 4. And we started July 1st of 2022, I think. I think that's when we started, July 1st of 2022. So we're just entering our year 4. All right, so let's go ahead and get started. This is part of physiologic adaptation. And again, I explained it to you in the intro. Physiologic adaptation has a lot of components under it. And this is the one where it talks about the complications of common problems. Okay, so common problems, people being on a ventilator, people having a chest tube, someone having hyperkalemia, someone getting blood, right? These are common problems. And then the complications of those problems. Can you identify the complication and do you know what to do about it? Okay, so there's a lot of clinical reasoning that goes on with these questions. The nurse is caring for a client with a chest tube for pneumothorax. Which findings indicate a complication requiring immediate intervention? Select all that apply. So you don't have to identify the well, actually you do. Let's read the answers. Sudden cessation of bubbling in the water-sealed chamber continuous bubbling in the suction control chamber, tracheal deviation to the unaffected side, tidling or fluctuation in the water seal chamber with respiration, pulse oximetry reading of 88% on room air, subcutaneous crepitus around the insertion site. All right, so they've had a pneumothorax. A pneumothorax involves getting air in the pleural space so that you have less surface area in the lung because some of it collapses. You have less surface area for gas exchange. And so usually the patient experiences shortness of breath. And they come in, they're like, I don't know what's going on. I'm having a hard time breathing. And they're like, oh, you got a pneumothorax. We have to put in a chest tube. So we do teach about chest tubes in the 21 plus hour clinic review. So I'm not going to do a ton of teaching on chest tubes because remember, I don't do the things here on the channel that we ask you to pay for as part of our services. But I will say that a chest tube is inserted into the pleural space for the purpose of removing air or blood, right? A pneumothorax is air, a hemothorax is blood. So it's inserted into the pleural space. So if it's inserted into the pleural space, then you have water seal chamber. You have a water seal chamber. The water seal chamber is what prevents air from getting back into the pleural space. Okay, so it prevents air from getting back into the pleural space. And you expect there to be intermittent bubbling in the water seal chamber. That's expected, intermittent bubbling in the water seal chamber. If you have continuous bubbling in the water seal chamber, that indicates possibly an air leak. If no bubbling in the water seal chamber, you've probably got some kind of an occlusion going on somewhere. So that's a problem. So you expect intermittent bubbling. A suction control chamber is where you connect the suction, but there's no water in it. So old school suction control chambers had water in it, and some of them still do. It's just not very common. So we hook up the suction to low continuous suction. So you expect there to be continuous bubbling in the suction control chamber, intermittent bubbling in the water seal chamber, continuous bubbling in the suction control chamber, and that's because suction is low continuous, okay? So if we say which of the findings indicate a complication requiring immediate intervention, sudden cessation of bubbling in the water seal chamber, I expect there to be intermittent bubbling, so that's a problem. Continuous bubbling in the suction control chamber, that's expected. So let's turn it into a series of true-false statements. We have to turn these into a series of true-false statements as it relates back to the question, and the question is a complication. So let's do that wording instead. Sudden cessation of bubbling in the water seal chamber indicates a complication. That's true. Continuous bubbling in the suction control chamber indicates a complication. That's false. Tracheal deviation to the unaffected side indicates a complication. That's true. Tidling fluctuation in the water seal chamber with respiration indicates a complication. That's false. There should be tidling with respiration. That means water kind of goes up and down. Pulse oximetry of 88% on room air indicates a complication. That's true. I told you it reduces the surface area. A pneumothorax reduces surface area for gas exchange, but that doesn't mean there's not enough surface area for gas exchange. Many people who have a pneumothorax can still have a normal O2 sat, and if it drops below 93%, that's definitely a complication. So that's true. Subcutaneous crepitus around the insertion site indicates complication. That's true. That means air is getting into the subcutaneous tissues. It's not a super dangerous complication, but you would need to notify the healthcare provider, see if they want to do anything about it. Maybe something needs to be adjusted in how the chest tube is been inserted. They may need to do something about that. Okay, so that's what we're going to do from now on with our SATA questions. We're going to turn them into a series of true-false statements related to the question. Don't ever relate questions to each other. Don't ever relate answers to each other. Answers in SATA questions don't relate to each other. They only relate back to the question. A client who is 24 hours post-op after abdominal surgery is restless, tachycardic, and has a BP of 86/52, which is quite low. Which intervention should the nurse implement? So the question is, you have a patient who's hypotensive, tachycardic, which means this is a significant low blood pressure. Some people actually can live with a blood pressure that low. This person is tachycardic and restless. So they have impaired tissue perfusion as a result. If they're tachycardic and restless, they have impaired tissue perfusion. and they came back from surgery, abdominal surgery, 24 hours ago. So this sounds like a complication of surgery. This is a complication of surgery. And it's probably, remember, you can use clinical reasoning here. You're expected to. It's probably bleeding. That seems to be the complication, right? So which intervention should the nurse implement? So I'm going to say, which should I implement for hypotension? No. Yeah, hypotension post-abdominal surgery. That's how I'm going to relate it back to the question. Okay, so we should assess the surgical dressing when they're hypotensive post-abdominal surgery. True. We should elevate the head of the bed when they're hypotensive post-abdominal surgery. All right, do we elevating the head of the bed a treatment for hypotension? No, it's not. You actually put the head of the bed flat. We should administer a prescribed fluid bolus when the patient is hypotensive following abdominal surgery. That's true. Remember, I talked a little bit about this in a previous video, but blood pressure equals stroke volume times heart rate times systemic vascular resistance. So you can change blood pressure by either changing stroke volume, changing heart rate, or changing vascular resistance. So if we give a fluid bolus, we're changing stroke volume, we're changing volume. So if we increase volume, we can increase blood pressure. We should notify the surgeon if the patient is hypotensive after abdominal surgery. Yeah, that's a good idea. We should document the findings and recheck in 30 minutes if the patient is hypotensive after abdominal surgery. So you have to understand that I'm not relating it back to any other answers, right? So I can't say I should administer a prescribed fluid bolus and document the findings. We're not relating it to other answers. This is a standalone answer. Is that what we do? And you have to understand on the NCLEX, documenting the findings means I'm not going to do anything. That's what it means. So if I document the findings and recheck in 30 minutes, that means I'm not going to do any of the other things because I'm just going to do that. So that's false. So I should check the hemoglobin and hematocrit levels if the patient is hypotensive following abdominal surgery. Yes, I should. I should do that. Remember, we're not saying I'm going to do this and this and this and this. We're just saying, is this as a standalone answer appropriate to do? And the answer is yes. So those are the correct answers for this SATA question. A client with acute kidney injury has a potassium level of 6.8. Which intervention should the nurse expect to perform? Select all that apply. So the potassium level is high. If this were on the NCLEX, they'd give you a range, and because that's what they're doing now on the NCLEX. So the range would be 3.5 to 5. So if they're hyperkalemic, which intervention should the nurse expect to perform for hyperkalemia? Place the client on continuous monitoring, administer sodium polystyrene sulfonate, administer IV insulin and dextrose, prepare for emergent dialysis, encourage potassium-rich foods, administer IV calcium gluconate. So remember, you're not saying I'm going to do this and this and this and this. Each one of these answers is a standalone, and you have to say, is this appropriate to do for hyperkalemia? So what I don't want you to do is go, well, I wouldn't do them all. That's not what it's asking you. It's saying, are each of these options appropriate if the patient is hyperkalemic? So placing the client on continuous cardiac monitoring is appropriate, is appropriate intervention when they're hyperkalemic. That's true. Administering sodium polystyrene for a hyperkalemic patient is appropriate. That's true. That's K-exalate. Administer IV insulin and dextrose for a patient who's hyperkalemic is an appropriate intervention. That's true. That's a standard treatment. Preparing for emergent dialysis is an appropriate intervention when the patient is hyperkalemic. If you don't know this, we actually do treat hyperkalemia with dialysis. Sometimes they'll go for a one-time dialysis treatment. Now, I don't know if this patient would, but it is an appropriate intervention to get their potassium down because dialysis removes electrolytes. That's part of what dialysis does. Encouraging potassium-rich foods is an appropriate treatment for a hyperkalemic patient. False. They're already hyperkalemic. Administer IV calcium gluconate is an appropriate treatment for hyperkalemia, and the answer is true. So this is a really good question to show you how you don't relate answers to other answers. You only relate answers back to the question. A client receiving a blood transfusion develops fever, chills, and back pain. What are appropriate nursing actions? Select all that apply. So what do we think is going on here? Well, it seems like they are having a transfusion reaction. Okay, so blood transfusion, they're having fever, chills, and back pain. It seems like they're having a transfusion reaction. So what do we do when they're having a transfusion reaction? I would stop the transfusion immediately for a transfusion reaction. True. I would send the blood and tubing to the lab for a transfusion reaction. True. I would administer acetaminophen and resume the transfusion with a transfusion reaction. False. Now, I realize that we don't relate them to other answers, but if one answer is the opposite of another answer, you can't do them both, y'all. You can't do C and A. Even though we're not relating them to each other, it just doesn't make any sense to do both of them, right? You can only do one of those. And I know I have to do A, so I'm not going to do C. I would maintain an IV access with normal saline when the patient has a blood transfusion reaction. True. I would notify the healthcare provider when the patient has a blood transfusion reaction. True. I would monitor vital signs hourly when the patient has a blood transfusion reaction. So actually that's false. I would want to do it a lot more often than that. A lot more often. If it said every 15, I'd say yes. I mean, honestly, if it said every 5 or 10, I'd say yes, but 15 is more common. A client with cirrhosis is admitted with confusion and asterixis. Which interventions are appropriate? Select all that apply. Again, you have to use clinical reasoning and say, what do I think is going on here? So in the previous video, the one where I just did complications and interventions, not SATA questions, just standalone questions, I taught you what asterixis was. I said it's hand flapping, and it's a symptom of hepatic encephalopathy. So this person has cirrhosis, which is liver problems, so they're at risk for hepatic encephalopathy. Hepatic encephalopathy is a result of increased ammonia in the body. I taught about it in the previous video, so I'm not going to teach about it again here. So you have increased ammonia level, which causes this hand flapping and changes level of consciousness. So confusion, and eventually they're going to become comatose. Okay, and eventually they'll die from it if you don't get it treated. So what are the interventions for hepatic encephalopathy? That's really what this question is telling you. I would administer lactulose as prescribed for hepatic encephalopathy. True. Lactulose binds with ammonia in the GI tract and excretes it, so they have to be very poopy after you give them lactulose. I would restrict dietary protein for a patient who's had hepatic encephalopathy. That's true because that's one of the treatments. Increased protein in your diet increases your risk for ammonia, and so we would restrict it. I would monitor ammonia levels for a patient who has hepatic encephalopathy. True. I would implement seizure precautions for a patient who has hepatic encephalopathy. Well, they've got a change in level of consciousness, so even if you don't know if seizure is a risk, you should say, this is affecting the brain, they're confused, they're having this hand flapping, which is some sort of strange nerve muscle stuff going on there. So wouldn't seizures make sense to be a risk factor? Like that just makes sense to me. So I'm going to say true. I would administer furosemide for a patient who has hepatic encephalopathy. That's actually not true. Now, if they had ascites as it relates to cirrhosis, then I could administer furosemide, but ascites is not hepatic encephalopathy, okay? We're not asking the treatment for cirrhosis. We're asking the treatment for hepatic encephalopathy, even though those words are not there. You're supposed to know that's what the problem is based on the symptoms, okay? So we don't administer furosemide for hepatic encephalopathy. I would insert an NG tube for feeding for a patient with hepatic encephalopathy. No, we would not do that. We would try to get them reverse the ammonia level, and then they can eat on their own. That's not a problem. So tube feeding is not a common treatment for a patient with hepatic encephalopathy. So these are the treatments that I would expect. A client with a newly placed tracheostomy is experiencing respiratory distress. Which action should the nurse take? Select all that apply. So what's the problem? Respiratory distress with a newly placed trach. Okay, so that's the problem, so I'm going to relate every answer back to that. I would assess for dislodgement or obstruction in a patient with respiratory distress who has a newly placed trach. That seems like a good idea. That's true. I would call a code blue for a patient who has respiratory distress with a newly placed trach. All right, that's false, y'all. Code blues are when your heart stops, when you're dead, your heart, no pulse. Okay, that's when they call a code blue. So it doesn't say they have no pulse. I would attempt to reinsert the tracheostomy tube immediately for a patient with respiratory distress with a newly placed tracheostomy. Y'all, I'm not messing around with any of that. That is outside my scope of practice. I am not going to do that. I would provide oxygen via trach mask for a patient who's experiencing respiratory distress with a newly placed trach. That seems like a good idea. I would elevate the head of the bed for a patient who's experiencing respiratory distress with a newly placed trach. Yes, that seems like a good idea. Elevating the head of the bed is a common symptom for respiratory distress, whether they have a trach or not. I would suction the trach for a patient experiencing respiratory distress with a newly placed trach. So I do know that, especially early on after the trach is placed, there's a lot of secretions that are stimulated because of the injury associated with the trach placement. So yeah, I would suction the trach to see if that would solve that problem. So I don't know if you find it easier to answer these questions correctly when I do it this way, this true-false thing where you go true or false related back to the problem in the question. But I'm telling you what, you're going to do way better on these SATA questions. And the good news is you get partial credit on these SATA questions. So that's good news. A client with increased intracranial pressure shows decreased LOC, level of consciousness, and irregular respirations. What are appropriate nursing actions? Select all that apply. So the problem is ICP, increased intracranial pressure. Now, I did a video not long ago on increased ICP. So hopefully you've watched it. And if you haven't, and you don't know the answers to this, just to go to YouTube and type in increased ICP clinic. Okay, so a patient with increased ICP, I would elevate the head of the bed to 30 degrees. That's actually true. That helps decrease pressure just through gravity. With that, I would cluster care to minimize interruptions. Minimize interruptions for a patient with ICP. Well, I would definitely want to minimize interruptions, but I don't know that I'd want to cluster care. So if I'm in there for an hour, doing everything for an hour, that's not helpful for a patient with increased ICP. I probably want to do something like decrease overall stimulation. So see what I can get rid of. Like, is there anything I can not do? And then try to space it out so I have minimal interruptions and minimal interactions. That's really what I want to do. So I don't like B. I would administer mannitol as prescribed for a patient with increased ICP. So mannitol is a diuretic that decreases fluid in the brain, actually. So that is the correct intervention. I would keep the neck in a neutral position for a patient with increased ICP. That's true because that helps with the draining of the fluid from the head. The same reason we do 30 degrees. So 30 degrees and a neutral position helps with the draining. I would suction aggressively to keep the airway clear in a patient with increased ICP. No. Suctioning, I would want to avoid suctioning as much as I possibly can because that just increases pressure, stimulates coughing, which increases pressure. So I don't want to do any of that. I would notify the healthcare provider for a patient with increased ICP. Yeah, that seems like a good idea. That just makes sense to me. Okay, so I'm still using my common sense, y'all. These are not things that you go, oh, I didn't memorize this list. Well, there are, remember I told you, this video and the previous one, the complications and interventions, do require knowledge. So there is knowledge associated with this. So it's not just common sense and clinical reasoning. But if you have good understanding of what increased ICP is, you probably could have gotten all of these things right. Maybe you wouldn't have known the mannitol one, right? You have to memorize that one. But the others sort of make sense, don't they? As far as you think of increased ICP. A client with sepsis is showing signs of poor perfusion, cool extremities, MAP of 58, and rising lactate. What nursing interventions are appropriate? Select all that apply. So I have a patient who's going into septic shock, right? So they're septic, and now they're showing signs of poor perfusion. Their MAP, mean arterial pressure. Mean arterial pressure is systolic plus diastolic divided by 3. So let's say the blood pressure is 100 over 50. So it'd be 100 plus 50 divided by 3. So that's 200 divided by 3, which is like 66 or something like that, right? So MAP is supposed to be over 65. It's supposed to be over 65 to ensure good perfusion. Well, here we have a MAP of 58. So that's pretty low. And we have a rising lactate. Lactate means that the body is engaging in anaerobic metabolism. It only engages in anaerobic metabolism when it's not getting oxygen because it's not perfusing and getting oxygen to the tissue. So we have poor perfusion. We have acidosis from anaerobic metabolism. That's what's going to happen with this lactate level rising. We have a low MAP. So we have a patient who's going into septic shock. So what do? For septic shock, we administer a 30 ml per kg crystalloid fluid bolus. So here you have to know, is that the right dose? And is crystalloid the right fluid? So crystalloids are crystal clear. 0.9 normal saline, lactated ringers are both crystal clear. We definitely want to do that. We want to use a crystal clear fluid like 0.9 normal saline or LR. And 30 mils per kg is the correct dose. Okay, that is the correct dose. So that's a knowledge thing. You do have to know that. For a person going into septic shock, we want to monitor urine output and central venous pressure. So central venous pressure tells us something about perfusion and volume, just like MAP does. And so yes, I can do those two things. Those are good ideas. For a patient who's going into septic shock, I'd want to start vasopressors if the MAP remains less than 65. So if you don't know what vasopressors are, I did talk about this in the last video as well, and I have some shock videos you can watch. Vasopressors, remember I told you blood pressure equals stroke volume times heart rate times systemic vascular resistance. So vascular resistance has to do with constriction and dilation. So vasopressors cause constriction. So it increases vascular resistance. So if you increase vascular resistance, you increase blood pressure. So vasopressors, if the MAP remains less than 65, that's a good idea for septic shock. If a patient's going into septic shock, I want to encourage oral fluids. Y'all, if patient is hypotensive and going into some kind of shock, oral fluids is not your option. You want, if they need fluids, it's going to be IV fluids, and which is what A is. For a patient going into septic shock, I'd want to obtain repeat lactate levels in 2 to 4 hours. True, because I want to see if my interventions worked. So I'm giving them this massive crystalloid fluid bolus, and I want to see if it worked. For a patient going into septic shock, I'd want to obtain repeat lactate. Oh, I already said that. For a patient going into septic shock, I'd want to prepare for intubation if the mental status deteriorates. Well, that just makes sense to me. That's just common sense, okay? So yes, I want to do that. All right, so those are the correct answers. All right, I hope this was helpful to you. I don't know what else to say, really. I hope you're doing well. I hope you pass your NCLEX. I've gotten tons of messages from people telling me they're passing NCLEX, people who are passing it on their third, fourth attempt. That's amazing. So I'm so glad. And if you want to meet me over Zoom, live over Zoom, you can sign up for our small group tutoring at clinicreviews.com. Thanks. Have a great rest of your day.